Okay. Welcome back to the afternoon session after lunch. The next session is the pre-operative staging and laparoscopic diagnosis by Dr. Tharathorn. Dr. Tharathorn is the young staff from the CELAS, graduate from the minimal invasive surgery fellow training and more study in Japan for 2 years in TMTU and Tokyo University. Please welcome the Dr. Tharathorn, new shooting star in MAS and upper GI, please.
Thank you once again for kind invitation and your introduction. Today I will talk about the pre-operative staging and laparoscopic diagnosis in gastric cancer. So I will cover about the recommendations from the guideline that you have learned in this morning, and the staging by EGD, endoscopic ultrasound, CT scan, PET scan, staging, laparoscopy. As you have learned in this morning that there are many guidelines nowadays, such as gastric cancer guideline from Japanese Gastric Cancer Association, or European guideline or ESMO, and from the American side called NCCN guideline. Let me start from the Japanese guideline. About the staging, the Japanese guideline recommend to perform endoscopy, CT scan, ultrasound, and staging laparoscopy in the schema. And about the ESMO guideline, the new update from Asian side, they mentioned about the diagnosis that should be made from the adequate biopsy from endoscopy. And for the staging, they recommend to perform upper GI endoscopy and contrast enhanced CT scan of thorax and whole abdomen, including the pelvis. For the Asian side of the ESMO guideline, they recommend not to perform PET CT scan. And both upfront surgery case and perioperative chemotherapy case, diagnostic laparoscopy is recommended. In ESMO 2024, the EUS is not mentioned. But for the full ESMO 2022, they mentioned about EUS that the EUS can be used for accurate assessment of T and N staging in resectable tumor. And about NCCN guideline, there are many lines of recommendation. The specific focus on staging, they recommend to perform chest and abdomen, including pelvis CT scan with contrast. And for the American side, they recommend to perform PET scan from the skull base to mid-thigh for locally advanced or metastatic disease, or if clinically indicated. And they recommend to perform EUS in early stage cancer. Moreover, they mentioned about the molecular testing like MSI or MMR and HER2 PD-L1 status. And for nowadays, they recommend to perform Claudin 18.2 also. And they also mentioned about the nutritional assessment and smoking cessation, and about the family history. For now, I will touch about the staging tools that we have to use nowadays, like EGD, EUS, CT scan, PET CT, and staging laparoscopy. So today I will focus about the locally advanced gastric cancer cases. Let's start with the EGD. Of course, we need to perform the biopsy of histopathology from endoscopy. Then, moreover, we need to assess the tumor, like tumor border or proximal and distal extension of the tumor, especially resection margin. From the Japanese guideline, the T1 margin, we need at least 2 centimeters of proximal margin. unlike T2 or deeper tumor, we classify as Borman classification that Borman type 1 and 2, we need more than 3 centimeters, and Borman type 3 and type 4, we need more than 5 centimeters. Of course, if we perform the accurate EGD, we can define the good margin for resection. In addition, we can perform the clipping or tattooing to define the location of resection line, especially proximal margin. As you may know, we classify the gastric cancer to early and locally advanced gastric cancer. For the locally advanced gastric cancer, we use Borman classification. For the type 1 and type 2, we need 3 centimeter of proximal margin. And the type 3 and type 4, we need proximal margin more than 5 centimeters. Sometimes tumor border cannot be identified clearly. We can use the dichromal endoscopy like acetic acid or indigo carmine to define the demarcation line as well. Nowadays, we have new technology of image enhanced endoscopy to classify or characterize the lesion like NBI. NBI we always use to characterize the tumor that be benign or malignant. And we have TXI mode for detection of early lesion. And sometimes if we perform the endoscopic treatment, we use some mode like RDI to differentiate the flow of bleeding. And this is the flow of endoscopic diagnosis. Firstly, we try to detect by white light endoscopy and image enhanced endoscopy. If we find the suspected lesion, we try to identify the demarcation line, and we try to predict the depth of invasion and predict that lesion is benign or malignant to decide the proper treatment like surgery, chemotherapy, or endoscopic resection. Next, let's move to the endoscopic ultrasonography. Endoscopic ultrasonography or EUS, very useful to visualize the deeper layers of GI tract, unlike the normal EGD, because we can identify only the mucosal side, but EUS we can assess the deeper layers of GI tract, and we can assess the nearby lymph node or adjacent structures as well. Roughly, we separate the EUS into two types. First is radial EUS and another is linear EUS. For the upper row is the radial EUS. It's very useful to staging, especially for gastric cancer. And for the lower row, this is the linear EUS. This tool is useful for retrieve the specimen like FNA or FNB. And this is the example of the finding when you perform the EUS. EUS can be used to predict the depth of invasion, especially T1 lesion, early lesion. Moreover, you can identify the size or spreading of tumor, especially in case of infiltrative tumor that infiltrate only submucosal area. You can characterize the lesion by echogenicity, the layer of origin in case of subepithelial tumor, and you can identify some high-risk features. And of course, you can identify the adjacent lymph nodes and adjacent structure like liver or pancreas. For the endoscopic ultrasonography, you can identify many layers from inside to outside. There are at least 5 layers. Depends on the operator expertise. Normally, to perform adequate ultrasonography, endoscopic ultrasonography, you need to deflate all the stomach air and infuse around 200 to 400 millimeter of water for gastric lumen dilatation. And you can assess the wall of the normal stomach. That normal gastric wall thickness is around 2 to 4 millimeter. The thickening of gastric wall more than 4 millimeters sometimes is a cancer. The common findings of gastric cancer in EUS, you can identify the inhomogeneous hypoechoic wall thickening that can be either focal or diffuse wall thickening. In early lesion, maybe affect only one layer, like mucosal layer, but deeper tumor, you can identify the thickening effects more than one layer, and you can define the border of tumor, eventually infiltrative tumors. About the accuracy of EUS in gastric cancer, of course, EUS is useful to predict both T and N staging. However, for now, the accuracy is still limited. The average accuracy is around 70 to 75% both T and N staging, because the EUS is depend on operator, and moreover, this kind of procedure needs sedation during the procedure, and some areas of stomach like EG junction, subcardiac, or lactic curvature is still limited by examination. And not only the operator, the technology of ultrasonography that developed day by day is still affect the EUS accuracy in gastric cancer. For the next, the CT scan. Of course, that I think the CT scan is very useful for all of us, because we used to do the staging of cancer for T and M staging, and we can identify the tumor location, the tumor extension, and relationship to the adjacent organs. And of course, the CT scan is our key investigation. The T staging, the accuracy is around 77% to 89%. The N staging, the accuracy is not so good. It's only around 70 to 80%. But for M staging, the accuracy is more than 90%, except the peritoneal carcinomatosis, that sensitivity only 50%. So the core of CT scan to detect the distant metastasis. The recommendation to perform CT scan, the buscopan 10 to 15 minutes before CT scan is recommended. Moreover, the 70 seconds after contrast injection is the optimal time for gastric cancer enhancement. And this is the finding of T1, T2, T3, and T4. Like this is a sometimes, like T1 staging, you can identify only some hyper enhancement of lesion without any wall thickening. For the T2 lesion, you can identify the enhanced, hyper enhanced wall thickening in the lesser curvature in this case. And for T3, the tumor, sometimes you can identify the inhomogeneous enhancements of the tumor of the wall thickening area, and sometimes you can see the spiculate fat stranding around the tumor. And sometimes T4A is difficult to separate from T3, because you can identify the spiculate fat stranding as well. But the T4A, you can identify the serosal involvement. Sometimes you can see by the shrinkage of that enhanced wall. And this is T4B. Of course, there is invasion to adjacent organ, like this case. There is invasion and fistula formation to the transverse colon. For the lymph node criteria for pathologic lymph node in gastric cancer, there are 5 items. First is short axis, more than 6 to 8 millimeter, and the lymph node turn round, and presence of central necrosis or loss of fatty hilum, and the enhancement is heterogeneous or high enhancement. Not only T and N staging, CT scan is very useful for identify the proximal and distal extension. And the vascular variation, especially for left hepatic artery, you need to carefully evaluate before surgery. And sometimes we use CT scan to diagnosis of gallstone and ovarian tumor in female. Next, for the PET CT scan, for the NCCN guideline, they recommend to perform PET scan for locally advanced or metastatic disease or clinically indicated, but not for T1 disease. That's totally different from ESMO and Japanese guideline that they recommend not to perform PET CT routinely because of the nature of the gastric cancer. Normally, the gastric cancer is mostly is mucinous or diffuse type tumor that cause lower tracer uptake in PET scan. So from ESMO guideline and Asian ESMO guideline and Japanese guideline, they recommend not to perform PET CT scan routinely. And about other cross-sectional imaging like MRI. MRI for nowadays, there are many recent techniques to increase the adequacy to use with gastric cancer. However, it's not recommended in current guidelines. Moreover, there are new technology like virtual gastroscopy that need to be performed after further research. And the last diagnostic tool, the diagnostic laparoscopy. As I mentioned before, the CT scan have limitation to diagnose the peritoneal metastasis. In peritoneal metastasis, size less than 5 millimeter, the sensitivity is only 11%, while the lesion more than 5 centimeter, the sensitivity is more than 94%. So diagnostic laparoscopy is a useful tool to diagnose the peritoneal metastasis. But not only diagnostic laparoscopy, you need to perform lavage cytology additionally. Mostly we use around 200 millimeter of normal saline to perform the lavage all quadrants. You can identify the patient that to be peritoneal metastasis, gross peritoneal metastasis, we classify as P1. But if there is no gross peritoneal metastasis but cytology positive, we classify as CYP1. The sensitivity around 84% and specificity is 100%. Not only the occult peritoneal metastasis, sometimes you can assess the tissue planes and the fixation to the posterior organ like pancreas during performing the diagnostic laparoscopy. There are many recommendations about diagnostic or staging laparoscopy among current guidelines. But for gastric cancer, as ESMO guideline, they recommend to perform in the resectable case with a high risk of peritoneal metastasis or candidate for pre-operative chemotherapy. And for NCCN guideline, they recommend to perform staging laparoscopy in resectable clinical T1B or higher, and with NEN or but clinically no metastasis. Not indicated for palliative resection. And for Japanese guideline, the newer one, they mention only who are likely to have peritoneal metastasis, but the former one, the 2018 version, they mention to perform staging laparoscopy in relatively high risk for peritoneal metastasis, peritoneal dissemination, and who is the candidate for neoadjuvant chemotherapy. In summary, the high risk of peritoneal metastasis, the patient is T4, T3, polycohesive, planned neoadjuvant, and also resectable. And how about which case have high risk for peritoneal metastasis? This is the summary from meta-analysis. The factor that predict the high risk for peritoneal metastasis includes lymphovascular invasion, Bormann type 4, polydiff, undiff, or serous type lesion, C3 or deeper, tumor size greater than 5 cm, and positive lymph node in CT scan. And the techniques, there are many high variations among the techniques. So for nowadays, there are no current recommendation about the techniques of diagnostic laparoscopy. But generally, when we perform the diagnostic laparoscopy, we try to connect to others by using the same term. We use the PCI score, or peritoneal cancer index score, that calculated by the lesion size and the involved region and calculate into the PCI score. And for the techniques, there are 4 standard steps. First, the anterior abdominal wall and visceral peritoneal surface was examined. For the anterior abdominal wall, the fashion is circular or clockwise, but visceral peritoneal surface we commonly perform in S-shape technique. Next, we move to observe the pelvic, parietal, and visceral peritoneum, including pelvic floor and pelvic organ in 30-degree Trendelenburg position. And for the third one, we move the patient to reverse Trendelenburg to observe the small intestine and mesentery. And the last, we perform the examination of stomach and adjacent area by lifting the stomach to observe the posterior infiltration. So this is my conclusion. For the EGD, we commonly assess the proximal resection margin. The EUS we use for T-staging, especially for early lesion. For CAT scan is our key diagnostic to define the distant metastasis. And PET-CT is not routinely performed. And staging laparoscopy we use in case of high risk of peritoneal metastasis or the candidates who need the neoadjuvant or perioperative treatment. Thank you for your attention.
Thank you, Professor Tharathorn. We will keep the question at the end of the session.